I want to introduce our next team of speakers. We have Dr. Tony Delitto, Professor and Dean of the School of Health and Rehabilitation Sciences at the University of Pittsburgh and co-director of the COSTAR Pilot Studies Corps. We have Dr. James Irrgang, Professor and Vice Chair for Clinical Outcomes Research, the Department of Orthopedic Surgery, School of Medicine at the University of Pittsburgh. And Dr. Kelley Fitzgerald, Professor and Associate Dean of Graduate Studies at the University of Pittsburgh and COSTAR co-director of the Pilot Studies Corps. So I'll hand it over to you.
Thanks. I want to echo with Gerard and Julie, how they started, and it's an honor to be up here. Talk to you a little bit about what we're calling, Model 2, but I think all of these models seem to have the same sort of underlying goal, and that's to implement change. That's what we're all trying to do. What I'm going to try to do here is think about implementing change, but think about what can catalyze change. This notion of change takes a while. We all talk about innovations and how long they take to be implemented in clinical life, and some people throw out these terms like 10 years, 12 years, 16 years. And I'm not sure that that we really take into consideration what can catalyze change. And I can tell you in our experience right now in Pittsburgh, what has catalyzed change are pragmatic trials, and that's what I'm going to talk about, and really how they've catalyzed change. And at the same time, what I really think about with the idea of pragmatic research, I want to give you a little bit of the context of doing this in an institution like the University of Pittsburgh. We're sort of no different than how Pam described an academic center last night and how Julie described an academic center this morning. We're not any different. I would like to even say, even though I'm on camera here, we're probably a little worse than others at Pittsburgh. The challenges in Pittsburgh are, number one, we're a very highly funded NIH institution. And what you can imagine from that is that the perception that people have with regard to innovation is that it's going to be discovered in the bench, and then it's going to be implemented. And that really is a lot of the background of a lot of people who go into this whole area. So their idea of this academic medical center that we have, that's really we're attached at the hip to our academic medical center, is many people's ideas to take these innovations that they've been studying for so long, sometimes funded by the NIH, sometimes just innovations that have been funded by other things, and just going to the health system and saying, it's time for me to implement this, let's implement. And what we fail to realize on the academic side is that we have a very mature academic medical center, that it's a well-oiled machine, and we're sort of surprised when our ideas just aren't that interesting to them. They have a lot of other things they're trying to solve here, especially with regard to some of the high priority areas. And the idea that when we start to think about work being more pragmatic, and the idea of going to health systems, and you start to get terms like partnership. What's really important to them? What are the problems they're trying to solve? And then you look for these perfect storms, and it's a whole different approach to it, especially when you're trying to do things in a much more pragmatic way, because that's what the academic medical center is looking for right now, especially with today's pressure. So this idea of doing pragmatic research and its role with facilitating implementation, I think is really an important component. The other thing that sort of catalyzes this whole process is when somebody comes along and all of a sudden decides they're going to fund pragmatic research. And we can thank PCORI for this, because really, for the most part, when I was one of these NIH-funded trialists. And when I saw pragmatic research, I kind of know what pragmatic means, from a thesaurus, but I didn't really understand it from the standpoint of, how it would change the approach I had to answering a question until I, got into it and started looking at it. And I felt like one of these fish going upstream. It was really a different approach. It was totally different. And we were a quick study. And like these fish going upstream, every once in a while, you sort of run into issues. Okay? And now this bear can represent a lot of different barriers that we've come up against. And I want to try to go into some of those because they're important barriers to overcome. The first barrier is obvious. I was a person from the academic side who came over to the clinical side and said, I want to help, I want to do some research with you folks. And right away, I had this look that was like, oh, here we go again. Somebody coming over from the academic side is going to try to solve our problems for us. And I'll just keep this bear in mind as I go through some of the other processes here. So I will explain the target trial a little bit. This is a funded trial from the Patient-Centered Outcomes Research Institute, but I don't want to spend a lot of time on it. I'm not up here to really talk about back pain. You've probably heard about back pain ad nauseum. But I really want to talk about how it fits, how the whole pragmatic elements fit, and with regard to how you go about doing this trial. And what you'll see from this is how, I hope what you'll see is how implementation is facilitated through the process. And keep in mind that, we are a CoStar site, and we have taken our CoStar postdocs and so forth, and we have engaged them in this process. They're learning about as we go through, they're learning about every part of this. So I'll talk a little bit about the PRECIS 2 and how it works with the target trial, and then some of the barriers that we've come across. So we're a national multi-site trial. Boston Medical Center up here is involved with us, and my co-principal investigator, Rob Saper, is up here. He's a family medicine physician. Johns Hopkins, Medical University of South Carolina, and Intermountain Health, as well as us in Pittsburgh at the University of Pittsburgh Medical Center. We answered a call for large pragmatic trials from PCORI, and the definition, large, national multi-site trial, real-world conditions, and answering important questions to patients, providers, payers, and policymakers. And this gets you into the sort of partnerships that you have to produce and create. And you have to answer a question that's of interest to PCORI, which was how can we stop acute low back pain from progressing to chronic low back pain? Well, guess what? That's an issue that was important to our health system. It was an issue that was important to all the other health systems that were out. When we first looked at the call, the first thing we thought of as academicians was, what's the biggest problem in trials? It's recruitment. So why don't we go where all the patients are? And in our area, the patients were, more than half of the patients start their episodes of care with chiropractors. So we thought we've got to recruit from chiros. That would be the obvious place it would be to start thinking about recruiting from. Until we until we started listening to some of our payers. And this slide that we got from payers was really, answered the question that we wanted in terms of recruitment. They're basically telling us primary care is where you really need to go, because they're the ones that's where we're having problems. This is data provided by Optum, which is on a very large number of spine-related disorders. And it's a busy slide, but bear with me. This is the percentage of episodes that opioids were prescribed on this axis. And on this axis is the percentage of time that imaging is prescribed for initial consults with early consults with, and this color-coded over here is where they started. And you can see that the blue is chiropractic. And these guys, the chiropractors, are doing pretty well. You know, this, by the way, if you're not familiar with guidelines, you know, you really want to be in this corner down here. You really don't want to be prescribing opioids. You don't want to be prescribing advanced imaging. And in the words of one of the largest payers in the country, you know, chiros are a high volume operation. They see a lot of patients, but they're really pretty low cost to the provider. What they really wanted us to look at were these greens in here, because these were the primary care physicians. There's two different groups of primary care. They're the people that are osteopathic trained and the people who are MD trained. And they're the ones where they're high volume, but they also they prescribe more opioids and they prescribe more imaging, and they're a more high cost. So this gets you right to the crux of it, which was in their minds we should be looking in the primary care environment, okay, and that's what we ended up doing. Then we had to go back to our sites and make sure that, you know, they had the ingredients to do a trial, and the ingredients were they had to be integrated systems with regard to primary care, and they had to be interested in the question. And all of the sites were in agreement that they weren't managing people with back pain as efficiently as they should be, and so that partnership was pretty interesting. So that was of interest to our partners. So in Gerard's next step, what are we going to study? You know, what's the thing to do? And the thing that stuck out with us right away, because we're in primary care environments, was the stratified approach to people with low back pain. And the evidence was there for this. We didn't have to go recreate it. In fact, the evidence was not only there, but they really conducted some of the trials in a different health system, in a European health system. So the thought was to see if we could replicate their findings in this country. Now, for those of you who want to, you know, who need a little primer on this, you know, this is really the implementation of a screening tool in primary care that identifies patients that need a more of a biobehavioral as well as a physical approach. And what they did, the innovation that was done in England, was that they trained physical therapists to do the biobehavioral approach along with the physical approach. And it's, you know, really, if you look at these questions 5 through 9, you sort of get the idea of what this biobehavioral approach ought to be. And it's important to understand this because, remember, you not only are screening these patients, but now you have to match them to a treatment. And how ready is the environment, especially in a pragmatic trial, to actually do this intervention? You know, it's not safe for me with a condition like mine to be active. Worrying thoughts have been going through my mind. This really points toward training that is above and beyond what most physical therapists have. So part and parcel to this application, we had to be thinking about how we were going to get this training out to the therapists in real everyday settings. I mean, we could have thought about this in a less pragmatic way and brought all these people to a special center where we trained special therapists to do this sort of thing. But the generalizability of that approach wasn't what our funder was interested in. They wanted something that was much more generalizable than that. So we decided on this psychologically informed physical therapy, where the intervention that was going to be matched to these high-risk people was going to be done through this not only physical functioning, but tailored stretching, strengthening, and address these psychosocial obstacles to recovery through education, coaching, and graded exercise, and addressing these terms, fear avoidance, as well as catastrophizing. So again, we had to, as part of our rollout of this, we had to package this training in a very pragmatic way. You know, and the way we decided to do it was through continuing education, standard continuing education. And again, you know, we were lucky that a lot of this blueprint was already done for us by the Europeans. Now, to make it a trial, you know, we had to, we decided on a cluster randomization where we would cluster randomize primary care clinics, not individual patients, and really implement two different processes of care in those practices. One that where if you look here, we would assess for eligibility patients who had back pain. We had to determine whether or not the patient was chronic, because we wanted only acute patients. And luckily, the NIH task force came up with a definition for us for chronic. And so we defined acute as anybody who wasn't chronic. Okay? And we administered the start back tool, and we administer the patient-reported outcome, the low back pain question, Swestry low back pain questionnaire. All of this had to be done in the normal process of care in primary care clinic, in our primary care clinics. So I'll just deviate here a little bit and talk about top-down versus bottom-up sorts of approaches to this. Our first stop for this were the managers of primary care clinics. And at the University of Pittsburgh, we have networked over 200 primary care clinics, and they're run by two separate operations. And we went to the heads of those operations, and who are sort of academically inclined, and they said, sure, this is a great idea. We'll be able to do this. We'll support you to do this. And luckily, we also went to some of the key managers of the primary care clinics who brought their primary care leaders to our meetings. And those meetings started out with, we'll do anything, but don't give us another thing to do. So you see the sort of disconnect. We spent a good deal of time, first of all, pointing out through data that a lot of their work was in back pain. A lot of they had a high prevalence of back pain, and through a period of time, convinced them, most of them, that this was probably a worthwhile venture for them. This was probably going to improve care. Meanwhile, keep in mind, they were also sort of under the gun here, because we're like a lot of other places. We were overprescribing opioids throughout our primary care clinics. We were overprescribing imaging throughout our primary care clinics. We were keeping that data. That data was being fed back to primary care clinicians. They were frustrated about it, and they realized that this might help. So it really that's the important part of this is the bottom up. As I said before, we exclude people who are chronic. And then we looked, using the start back tool, we have low and moderate risk patients that we're going to be recruiting. But the real trial are on these high risk patients, where we have two different interventions, and this is where the cluster randomization takes part, where in the one arm of the trial, we review the guidelines that are out already with the primary care clinicians. They get all of the data from the baseline eligibility, and we let them manage the patient like they normally manage them. In this other arm of the trial, we've really worked real closely, and I'll go into the detail about this, but in essence, if a patient is high risk, there's a very high probability, based on how we set up the electronic health record, that they will get a referral to physical therapy, and that referral to physical therapy will say psychologically informed therapy. And it's wired that way, and I'll show you how we implemented that in a minute. So, are all the patients going to get this? Well, they're going to get a referral. The physician can override that referral, right? Just getting a referral doesn't necessarily guarantee they're going to go to get the care. But probably in our minds a lot higher proportion than would be in just the guideline-based group. Not because of my feeling about the whole thing, but just on what our data told us. Less than 20% of the patients that were being seen in primary care were being referred to physical therapy. So it was a good bet that would probably continue throughout the study. And then what we're doing is 6-month follow-ups and 12-month follow-ups, where we're finding out if they transition to chronic, and we're looking at their functional outcome, and we're looking at resource utilization. And we're doing that in the groups that we're randomizing, and we're also doing that in this observational cohort, the low and moderate risk people. So when you think about, we're going to have about 9,000 patients when it's said and done in this observational cohort, and about 3,000 patients here. We'll have initial data on them all. We'll be able to obviously do our aims with the study, but we'll have a huge data set for future co-star trainees. So going through this now, I'm going to go through each of the areas of the PRECIS tool and talk about how I think we do a pretty good job of being predominantly pragmatic. You know, we cluster randomize this in real primary care environments. In fact, we purposely in Pittsburgh did not use the academic primary care clinics because we were told by the community primary care clinics that just because if it works there, don't assume it's going to work for us because they have way more resources in the academic side than we have out in the community. So we purposely stuck to the more community-based primary care practices. And we were able to convince Institutional Review Board, as well as, Institutional Review Board, that these two arms of the trial in the primary care clinics were accepted standards of care. You know, all we did was automate a referral in one arm, right? But you know, and this had far-reaching ramifications. First off was the fact that we did not, for the part of the study where the patient is in the primary care clinic, we were able to get consent waived, all right, and we were able to get HIPAA authorization waived in 4 of the 5 centers that we have, okay? That was a huge deal because what the primary care clinics were telling us is that we don't have time to consent patients. You know, we barely have enough time to get patients through. You know, and where we had problems with that was not necessarily the institutional review boards, right? But really the bigger problem were in the risk management component of each of the institutions. So what was required from an institutional review board process is not the only hurdle you have to jump when you're doing this kind of work. You also have to get people to eventually sign contracts, and this is where the risk people get involved. And it's a different. They're looking at it in a totally different way. Now it's less pragmatic when you add what some of the other sites have. The Medical University of South Carolina said that they basically had documentation of consent was waived, but still somehow consent had to be obtained. Is going to have to be obtained in primary care clinics. And the jury's still out with regard to how Hopkins is going to go through with this. But for the sites that we're going to be recruiting in the next year, we have both HIPAA authorization as well as consent waived. Now, we are going to need to obtain consent for the patient-reported outcomes for 6 and 12 months. We couldn't make the case that that was a part of a standard care, right? But that can happen after the patient's out of the primary care clinic, which is what the real bottleneck was for us. So we still think this is largely pragmatic. Now, think about this now from the standpoint of implementation. All right, let's assume this one of these approaches works, okay, or assume the experimental approach works. It's really an easy thing to implement now. The whole process is in the electronic health record. The whole process, as I'll go through, and this is how it happens. We learn more about. I learned more about Epic Care than I probably care to learn about it. But really, there's 2 ways to get a patient to start this process with a patient, and one is called a visit type, and the other is called an order type. And what the primary care clinics really like is when the patient's pre-identified, if there's a visit type. So that means the patient has to be identified. That it has to be identified when the patient calls in and schedules that they had the primary reason for the visit is low back pain. And if you set that up beforehand, and that allows the central scheduler to determine that this is why they're coming in, and you can actually get the whole process teed up. And you can get it teed up in a couple of ways. You can get it teed up either with the patient portal. Most electronic health systems have a portal. So a patient gets an email, you send them to the portal, and they fill that information out before they even get to the primary care office. Or we also implemented tablets. The primary care physicians told us if they had tablets, they could fill us out in the waiting room. And if we get our data is showing us now, because we've been recruiting for 2 months now, and we've got a lot of patients that have come through in Pittsburgh, we get data on well over 90% of the patients when they're identified beforehand. That just shows you how and we're down, and now if the patient is identified after they get there, that back pain, in other words, the patient is identified usually when the patient's in the room and the primary care physician's right in front of them. If that patient we wait that long to identify them, we're only getting the data on 40% of the patients. So what's our strategy? Our strategy is to try to get patients identified early on. We've got a new thing out with our medical assistants where they're asking patients now right up front, are you there, for back pain? Because we know that if we can get them identified earlier, we're much more able to get the completed data sets that we need. So the tools for collecting the data are the portal and the tablet, and then we have manual entry in the room when the primary care physician is already there. That's what we want to avoid. That's what and our primary care physicians are actually helping us out with that. Now, when the medical assistant reviews this collected information, and let's assume that they're in they're high risk, right? Then one of two things happens. Okay, this MA reviews this information. It's retrieved and an action is taken. If they're high risk, right, and they're in the guideline-based care arm, the physician is told about the information, and they can behave however they want to behave. If they're in the high risk and they're in the PIPT arm, okay, then an order is penned for PT, and the default is that order will be administered. The physician can override it, but it's important to keep in mind the default is the order will go, and all the physicians are okay with this. Sometimes they do have an option to not place the order. And then the last thing on this is we're an integrated system, so that order doesn't get handed to the patient. That order gets sent to the physical therapy operation that we have that's integrated, and it's the therapy companies. They call the patient and schedule the appointment. Again, this was pragmatic in a sense that the primary care physicians say that's where they lose. They lose a lot of referrals that way. Patients go to the front, they pay, they leave without taking their referrals with them. This way, the person with the vested interest calls the patient to get and tracks them down. And we even have a provision where if the patient doesn't want to come to our clinics, they want to go to another clinic, our clinic has agreed to facilitate that process with them. So this PRECIS 2 tool, it's this pragmatic explanatory continuum indicator summary. I'm going to go through each of these domains and talk about how making the trial more pragmatic just facilitates implementation of the whole process. The whole idea here is that the more pragmatic, the more generalizable the study, although you may lose some of the things with regard to internal validity. And this is what the tool looks like. And if the more pragmatic you are, the more on this outside you want to be. So 5 is out here, and this is where we wanted our trial to be on the outside with regard to eligibility, recruitment, setting, organization, flexibility of delivery, flexibility with regard to adherence, follow-up, and the primary outcome. And what I want to basically go through is a few of these and talk about some of the barriers and things. So what did we do with regard to eligibility? When you look at an explanatory trial, which was what I was used to doing, you included lots of exclusions. Those who don't comply, those who don't respond to treatment, those are not at high risk and everything. And to keep it more pragmatic, you really want what are the kind of patients that are coming into primary care anyway? Who are the patients coming in? We really, for the most part, eliminated chronic, right? And we eliminated people who were less than 18, largely because they're in a primary care setting, those patients many times, unless it's family medicine, they're still seeing their pediatricians. So they're not seeing a lot of people who are less than 18. And we eliminated red flags, which is legitimate. But after that, we're just taking on everybody that comes in. We didn't exclude pregnancy. We didn't exclude compressive nerve root signs and symptoms. Again, gets to the point of it being highly generalizable. Now, what were the barriers here? Well, one was that we have to discover red flags now through electronic health records because there was really an unwillingness on the part of primary care to actually click a button that said no red flags. That was a hard thing this was a very difficult thing to do. It wasn't just the fact that they didn't, in their minds, they already exclude red flags. They don't need a button there to do it. And putting a button in, it's a lot harder than it sounds. You know, it really is. It's a programming issue and everything. Epic programmers. I used to think in our institution that parking, everybody answered to parking, you know, including our CEO and our senior vice chancellor. But I'm now believing that our CEO answers to epic programmers. They're the people. And it was not it was so hard. We actually now realize that, you know, and it's legitimate to do that, we'll need to sweep the health records for red flags later on. And that's how we'll exclude red flags. The setting, you know, we could have done a single center, really, you know, highly specialized academic centers and probably control things a lot better. But what we really wanted to do is get identical settings that these patients were being seen in. And I thought what we did in ours is, you know, and we're doing this, it's on the very pragmatic side. So all the care is delivered in the normal operations of primary care settings. This referral to PIPT is generated from a start-back score in the electronic health record, completely legitimate with regard, I mean, it's highly generalizable. These are the guideline-based care plus the psychologically informed PT is taking place in community-based centers, not in any specialized PT center. And all the data that we're using is derived from the electronic health record. So even the patient-reported outcomes will be eventually get into the electronic health records, and we'll be analyzing that data. Now, the patient-reported outcome at 6 and 12 months, all right, we are collecting that separately, and we'll merge that data later. But the initial component is in the electronic health record already. With regard to organization, we really think that this is where we started to get a little more explanatory. The referral asked for psychologically informed therapy, which, as per the stratified approach, this we thought was reasonably pragmatic, but we couldn't just send people with that referral out. And even PCORI, when we were going back with them about this and talking about it, the idea was, you know, if you didn't want to end up with two arms of the trial where the same thing was happening in both arms. There needed to be a better assurance that this care was going to happen and be matched up. And so we hold courses on the psychologically informed therapy, and we held them at each location. And the PTs who received these referrals, we actually got the primary care physicians to specifically target letters to those practitioners saying that these referrals were on their way, and then encouraging to send their therapists to these courses. However, the courses was not a prerequisite to get the referral. That makes it a little more pragmatic. And we tried to keep the time frame consistent with both the evidence that was out, what the Europeans had done, plus keep it within the continuing education unit range for most licensure in states. Delivery and adherence, I think it's both pragmatic and explanatory. From a delivery standpoint, it's administered by practicing PTs in the geographical area. Training courses were offered through normal continuing education requirements, but we did add a checklist so we expect therapists who get these referrals to fill out a checklist. The checklist looks like this, right? And really, for the most part, these bulleted items on the top, these first three, are really related to the psychologically informed therapy. And these checklists get sent back to the primary care physician and put into the electronic health record. And it's about the only thing we have that really gives us an idea about treatment adherence. And again, this treatment adherence thing, compliance is not pragmatic. it's less pragmatic to do it this way. We think that this is a little more on the pragmatic side in the sense that there is communication between physical therapists and their referrers, right? This just is a little bit more meaningful than some of the communication that we generally send to them that has to do with, please sign this referral for more visits. The follow-up outcome and analysis, the 6 and 12 month is not part of standard care, but by the time we do it, really we're not interfering with the care that was delivered early on. And these, the Oswestry Low Back Pain Questionnaire was vetted by patients. More importantly, it was also vetted by providers and payers. This seems to be patients seem to think that the items on this list are really what's important to them. We went through a whole process with that. And of course, we do intention to treat, observational analysis. You know, most of us who did trials before, we all were aware of intention to treat. I mean, you know, you have to include everybody, so forth. So, so far, what we've done, this is rolling out the process for us. Our official recruitment date was May. We started recruiting officially on May 2nd, but this is all of the rollouts. You know, in our 31 primary care clinics, which are, you know, we for the most part have over 1,000 questionnaires assigned. We weren't quite at the 100% completion rate. We are in May. This was a little surprising to us. 40% of the people are reporting chronic. We thought it would be a little more like 80% acute, 20% chronic. Right now, the May figures are more like 50-50. And as I said before, we're getting pretty good capture rate as long as the patient identifies themselves as you know, beforehand. And we're getting about 25% high risk from the start back score, which is around what we thought we'd get, right around what we thought we'd get on that. So we'll keep on. So I want to talk, I want to have Jay come up now. He's going to talk a little bit more about outcome assessment. You know, the outcome we used in this, that we're using in the target trial is Oswestry. It's a legacy instrument. I think we need to be thinking a lot more about our outcomes and how we're going to be, what we're going to be doing with outcomes in pragmatic trials as our institutions become more mature about collecting outcomes and about looking at system-wide approaches to the outcomes. So, Jay?
Thank you, Tony. And again, I'm very happy to participate in this symposium. And basically, what I'm going to talk about is some of the things that we've done that were actually part of planning for a grant application to look at how can we incorporate collection of patient-reported outcomes, primarily focusing on physical function throughout an orthopedic service line in an academic and community-based organization that also included physical therapy. So as part of that planning, we hosted a summit in Pittsburgh last September. And the purpose of this was to gather input from patients as well as key stakeholders to determine what constructs are important to the stakeholders, to look at the methodological and logistical considerations for collecting this information within standard clinical care processes, and what factors needed to be considered when we wanted to interpret and actually use that data to improve patient care, to enhance quality and value-based care initiatives, and to promote clinical research. So this summit was a day-long program that we held in Pittsburgh, and it was a moderated panel discussion. We had a individual that was trained in leading focus groups. We generated some directed questions that individual used to guide the discussion. And then there was a time where there was open discussion from the floor. So the panelists included patients with a variety of orthopedic problems. Again, this was focusing on trying to integrate this within an orthopedic service line. We had clinicians in the same room with the patients. So we had orthopedic surgeons, primary care, physical medicine physicians, physical therapists, and occupational therapists. We had health systems administrators. So we had our vice president of orthopedics, of the orthopedic service line. We had the chief financial officer from our physical therapy organization, the Centers for Rehab Services. We had practice managers. We had QI representatives as well as representatives from the electronic health record. And then we had measurement experts, both representing AMPAC as well as PROMIS. So the first thing that we kind of focused on is, what and how to measure. And so measuring physical function for patients with orthopedic problems was important to the patient as well as the clinicians that cared for those patients. And the patients are actually willing to complete these patient-reported outcome measures of physical function, provided the questions that they were asked were relevant to their condition. They didn't want to be asked things that didn't pertain to them. And the clinician stated that the measures should be targeted and customized to individual patients, and everybody agreed that this should be completed within 5 to 10 minutes. So what does this imply for setting up a system to collect these patient-reported outcomes? Well, I think what we really learned, and it really caused us to change our grant application a lot, is that patients really need to be involved in reviewing and selecting the outcome measures. The items, the questions need to be relevant to the patient given their region of impairment, as well as their level of function. So what do I mean by that? So for individual with an impairment of lower extremity, appropriate items might be related to mobility, walking, climbing stairs, rising from a chair, running, and so forth, but not items related to upper extremity function, such as walking, or such as writing or placing an object on a shelf. We also have to think about their level of physical function. Okay, so for low-functioning individuals, items related to running, jumping, cutting, participating in sports are not relevant for those individuals. We also found from some of our other research that review of the items are actually important to make sure that the patient's understanding wording, what the question is asking, and the clarity of the item. So in one of our studies that was funded to look at the use of PROMIS for patients with a variety of knee impairments, patients really had trouble answering this question. Does your health now limit you in doing vigorous activities such as running, lifting heavy objects, participating in strenuous sports? You're asking them about 3 distinctly different topics, and the patients didn't realize or indicate that their knee impacted their health, okay? So we need to identify these problematic questions and I think either eliminate them or revise them. Our measurement experts really pointed out the fact that there are some new advances in measurement, namely item response theory and computer adaptive test, that can be used to create targeted outcome measures for individual patients. So without going into a lot of detail, just one slide on item response theory. Basically, it's a series of mathematical equations that models how a patient responds to the question based on the characteristics of the person, in other words, their level of function, and the characteristics of the question. How difficult of an activity is that question representing? And essentially, we get a curve where what we're trying to measure is on the horizontal axis, and the proportion of individuals that answer positively to that question is on the vertical axis. And we're just looking at that relationship. So as an individual's level of physical function improves, their probability of saying that, yes, they have no difficulty with that activity increases. And what this allows us to do is to create a calibrated scale to which all of the questions are linked. So an example here, a ruler to measure mobility, and it ranges from very low to high levels of mobility. And you can place items on this scale. So an item such as walking 1 block might be in the middle of the scale. Running a mile is at the higher level of the scale. Turning in bed is at a lower level. And then you can link other items on this scale based on their difficulty. So what this allows us to do is to utilize this calibrated item bank for computer adaptive testing. So basically what happens is that a computer will select the questions that are administered to the individual based on prior answers to questions that had already been administered. So the computer might start with an individual that is a 70-year-old male. The initial question, based on the best guess of where their mobility might be, is how much difficulty do you have walking a block? If they answer yes to that question, that they have no difficulty walking a block, that bypasses easier questions and might ask a more difficult question, like how much difficulty do you have walking a mile? And the process continues iteratively until function is estimated with either some predetermined number of questions or at a certain precision level. And the examples that we have in rehabilitation that are applicable, computer adaptive tests, are things like the AMPAC, the activity measure for post-acute care, or PROMIS. But there's lots of challenges in implementing these computer adaptive tests. The computer algorithms are not widely implemented within clinical data systems. Options for PROMIS are expanding. Up until recently, everything had to go through their assessment center. Now, the PROMIS computer adaptive tests are part of the library for REDCap that you can access. They've created what is known as an Assessment Center Application Programming Interface, or an API, that allows a health system to run these programs locally on a server that can be integrated with the electronic health record. This is what the University of Utah is doing, and another leader in this area is the University of Rochester. And it's been reported publicly at a meeting in Chicago several weeks ago that the 2016 release of EPIC is supposed to make the PROMIS computer adaptive test available. Now, as an alternative, you can certainly utilize short forms, and you're creating targeted forms that are static, that could be administered electronically, that would be targeted for individuals at certain ranges of physical function. And going forward, I think there's going to have to be efforts to link these different systems and different outcome measures onto a common metric. So what is happening with a group called Health Measures is that they've developed what is known as Procedistone. So now looking at the issues related to implementation. So it's obvious to patients when they participated in our summit is that the information was not reviewed by the clinicians, because when they got in the room, the clinicians asked them the same questions. Okay, that's not good. Patients also want to know what the scores mean. They really have no idea why these data are being collected. They want to know what the scores will be used for and how it impacts their care. So this is a quote from a patient that participated in the summit. If there's no further discussion of the outcome scores, it must not have been important. Okay? That's not going to motivate the patients to complete them on return visits. They also noted that the process would be easier and less burdensome if the outcome measures could be completed at home prior to the visit. From the clinician's point of view, they recognize that the patient-reported outcomes data could be useful to enhance provider-patient communication that could then be used in shared decision-making to help set expectations and determine the needs for treatment. However, those results need to be available immediately during the calendar. What the physicians didn't realize is that the data that we have collected is immediately available. They just didn't know how to access it or where to look for it. And they have to understand what the scores mean. The office staff said that there's a lot of technical problems with the computers, timing out, battery life that need to be dealt with. And there's lack of familiarity with the measures, which interferes with their ability to answer the questions that patients have. So what does this mean? So if we're going to implement this, we need a systems-based approach to ensure successful implementation. This should include process mapping to understand the clinic workflows. It should include audit and feedback of compliance and data use and collection to the clinicians and the staff. Certainly going to require quality improvement coaching to improve the performance of low-performing clinics and to maintain the performance of the best clinics. We're going to have to interview clinicians and staff to determine barriers and facilitators to implementation, as well as patients and talking to them to see how this information is being used and collected as they are receiving care. And ultimately, we're going to need to develop training materials that are targeted to the patients, the clinicians, and staff to address barriers to successful implementation. So if we can systematically collect patient-centered outcomes within standard of practice, and we get that information used, so it's not just being collected, but it's actually being used in the patient interactions, it has the opportunity to improve patient-centered care, certainly facilitate quality and value-based care initiatives, provides a rich source of data for pragmatic comparative effectiveness and observational research, and ideally should provide a source of data to populate registries. So one of the other hats that I wear is that I am the scientific director of the Physical Therapy Outcomes Registry, which is being developed by the American Physical Therapy Association with a vision of collecting data that can transform the practice, the profession, and patients. And the registry is an organized collection of process of care and clinical outcomes data that ultimately will be used to inform practice as well as payment, for quality improvement initiatives, and certainly for research. So when we look at what's included in the registry, there's really a core set of data elements that includes information that's applicable to all patients that are in the registry. So some demographic characteristics, information about the episode of care, the onset date, the discharge date, the number of visits, and so forth. There's visit data looking at who's actually providing the care, the charges associated with that, and pain and functional status measures, and then information about the providers. So the core constructs of the registry that are going to be the outcome measures are measures of pain and physical function, broadly including mobility, daily activity, and self-care. And ideally, there's a common metric that these outcome measures are linked on that will allow those measures to be appropriate for a full spectrum of patients that are seen by physical therapists. And in the future, there will be consideration given to inclusion of a multi-dimensional quality of life measure. The registry is also working on developing population-specific modules, which is a specific set of data elements to describe and risk-adjust process of care and clinical outcomes data for defined populations of patients. So in listening to Pam's presentation last night, it'd be really nice to have a module for patients that have had a stroke that is included in the registry that would implement and allow for collection of a lot of the things that she is doing in her research. We've discussed what information should be included in these modules, and really it's a tiered process that looks at what data can be optimally collected. So tier one, essential, patient classification diagnosis system, population-specific outcome measures, and other variables that are necessary for risk adjustment. Specific interventions would be in Tier 2, and then ideally, but the most difficult to integrate, is symptoms and physical examination findings, and all of this should be linked to clinical practice guidelines. So the timeline is that we are just closing a pilot project now. There will be a soft launch of the registry at the private practice section meeting in Las Vegas in October, and a large public launch at combined sections meeting next year, and we hope to have over 1,000 users in 2017. So successful collection of patient-centered outcomes within standard of practice, at least from my point of view, requires patient input to identify the relevant outcome measures that are important to the patient, use of modern measurement theories to deliver targeted and customized measures for the patient and their condition, and then a systems-based approach to implementation that considers the viewpoints of multiple stakeholders. Thank you.
I think we have time for a few questions before the break, but we wanted to keep that a little short.
Okay.
Hi, Lisa Silverstein from Newman University. My question relates to using function as our only outcome measure. My concern is that sometimes patients, and I've even experienced this myself, where I've had pain, and it's when I try to do the form, the function form, I realize that it's not impacting my function yet, and to wait until it impacts function to address it, I feel like goes against our goals of getting people in early.
Yeah, so yes, absolutely. Pain is an important thing that we deal with in physical therapy. That is certainly a core data element in the registry. For the purposes of our grant application, we were primarily interested in measuring physical function. It doesn't mean that we wouldn't record pain, and there's probably many other variables that would be needed to further interpret those measures of physical function to either risk adjust or risk stratify those measures. So it's certainly a lot more data than just physical function, but that's the point that we started at with our grant application.
I'm David Hickam. I work for PCORI. We're a supporter of Dr. Delitto's study on the transition between acute and chronic low back pain. I think Dr. Delitto did a really nice job of describing the PRECE classification system, and I just wanted to say a few words for that. We do not, at our agency, sort of try to put out the point of view that the more pragmatic a study is, the better. And I really like the way that Dr. Delitto basically used the PRECE tool the right way, which is descriptive. It gives you an idea of some of the considerations that were used in the design of the study, and that I think that in all studies, it's important to really think through the trade-offs between a more pragmatic approach and a more explanatory approach. And I think you did a nice job of sort of striking that balance. What we're interested in studies are studies that at the end produce valid evidence, and sometimes a more careful or what might be considered explanatory approach to a trial does produce better evidence. So always sort of think through the benefits and disadvantages of decisions you make in terms of conducting your study along any of those 6 axes that are included in the Preci tool. So, but it's a great descriptive way of trying to describe your study.
Hi, Jennifer Stevens-Lapsley at the University of Colorado. My question is related to the emphasis on PROs, and it complements a question on pain, as opposed to performance-based measures. And in some populations, they tell very different stories and provide complementary information. But yet the actual time it takes to do performance-based assessments is a barrier for wide-scale implementation. But what's your take on, I think joint replacement's a great example where there's completely opposite responses in terms of what we see with performance versus self-report measures. What do you think is the future of being able, and the feasibility of being able to really assess performance outcomes?
Yeah, that's a great question. And I think that, yes, there's definitely can be a disconnect between pain relief, patient-reported outcome, and performance-based measures of function, say, after total joint replacement. And there are obviously a lot more logistical issues in trying to integrate performance-based measures in standard clinical practice. Doesn't mean that it can't be done, but I think if you're going to do that, you really need to think about how that fits into the workflows, and whether or not it's part of standard clinical practice already, and working collaboratively with the clinicians that would need to be collecting that information. We have some experience in having our students collect some patient or some performance-based measures in kind of an acute care or rehab setting as part of a performance improvement project. And there are some struggles with that, but if they are standard performance-based measures that are already part of clinical practice, I think you're going to have a better chance of success.